And welcome everyone to the Alive National Centre's 21st Virtual Cafe Translation Conversation. Today, we have the pleasure of having Lisette Kaleveld speak to us on making mental health support work better for regional communities. Oh, uh, thanks, Carolyn. So first of all, the implementation and translation economics team, we'd like to acknowledge the traditional custodians of the land, sky, and waterways on which we meet and pay respect to elders past and present and to all Indigenous people who may be here with us online today. Today, Nisman and I are joining you from Nipaluna, Lutruwita, which is Palawa country, Tasmania. I'd also like in terms of a note on language, the Alive National Centre spans many diverse and wide spaces of mental health, mental ill health, distress, suicide, and social and emotional well-being. In terms for many of us, we may find some of the language or framings that people may use today, not always what we would prefer, or we may experience some discomfort with some of the language employed. Therefore, please take a break, grab a cuppa, do what you need to do, and leave and rejoin us, whatever you need to do. We would like to recognise the lived experience within the room today, and that we speak honourably and respectfully about ongoing emotional distress, experiences of trauma and mental ill health, and the work of caring and experiences of care within this context. The Alive National Centre, if you are new to the Alive National Centre, our mission is to transform mental health and wellbeing through primary care and community action. Our vision: vibrant communities that support mental health and promote wellbeing to enable people to thrive. We have the values of lived experience, practice wisdom, outcomes-driven, inclusive, authentic, and brave. We have 4 programs of work: prevention across the life course, longer, healthier lives in priority populations, the Lived Experience Research Collective, and mental health care at scale. Down the bottom, you can see we have a number of networks within the centre: the Co-Design Living Labs with 1,932 members, our Implementation and Translation Network with 50 members. We have the Next Generation Researchers Network with 275 members, of which 245 comprise our Lived Experience Research Collective. We also have broader engagement through the Alive Collective. So Alive, we're obviously a large collective where, in terms of what we do, there has been many recent, we're active in what we're doing, and in terms of updates, as you can see here, we've recently had actions to the call released. That's in terms of casting the net for what matters and for whom. We've recently had the online short course. We've had the NGRN Funding Galaxy Q&A event and new publications. And please, the 2024 Lived Experience Priority Survey for young people is currently open and closing soon. So please pass that on or undertake it as appropriate. Dana, thankfully, is providing all those links over in the chat for us. So today, the talk is being hosted by Nism and myself. We are the Implementation and Translation Economics Group, and we are part of the broader impact evaluation team for Alive. We are focusing on assessing the broader social value being created by the Alive National Centre, and our research is gaining an understanding of impact or health research impact according to the NHMRC, and how this relates to the work of the centre and where it's reflected in and supported, where our work is reflected in and supported by this framework. We're looking at assessing knowledge and other impacts that the centre is achieving, and also progressing towards an assessment of the National Centre's social return on investment. So today we're here to listen to Lisette Kaleveld. Lisette is a social researcher and evaluator with experience working in education, health, alcohol and other drugs and mental health, and evaluating programs that address homelessness and legal issues. Her focus is on demystifying research methods and increasing confidence in using evidence to support decision-making and practice. In mental health, Lisette has led research projects to better understand the social determinants of mental health and well-being, as well as solutions that sit outside of clinical settings. Lisette is co-convener of the Western Australia branch of the Australian Evaluation Society and is a senior research fellow at the Centre for Social Impact, UWA. And I'd now invite Lisette to join with us and look forward to listening to your presentation. Thanks, Lisette.
Thank you, Amanda, and it's so lovely to be here today. The report that I'm presenting on is a couple of years old now, but it's still one of my favourite pieces of research that I've ever done. And so it's really nice to be able to dialogue with a national audience, and I'd love to hear your perspectives later on. We'll just... So the report is called Going the Distance, and it's available publicly. So I'm interested in, you can find it in the report later on. And I'd like to acknowledge my team, which I worked with Emma Crane and Yasmin Hooper on the research and write-up. And I'll talk about WAM in a minute. I'd also like to acknowledge that we are today, or I am today, on the unceded land of the Whadjuk Noongar people, so over in Perth, WA. I'm going to start with the thank yous, just because I think that helps set the context. Basically, we're a research centre sitting within the University of Western Australia, and the West Australian Association for Mental Health approached us to collaborate with them on this. So it was an amazing opportunity because what WAM brought to the table was their expertise in engagement, in their networks throughout WA, obviously a little bit of funding to do this work, and also Colin Penter, who was critical in reaching out to communities, having conversations, and helping to make the findings. Colin Penter, I believe, is in the room today, so perhaps he can wave, or maybe later on it would be good to hear from him as well. And also acknowledge the team at the Centre for Social Impact. I'm going to outline the methods and questions, key findings, if there's time, a case study of a remote community, look at some solutions, and hopefully open up the floor for some questions and discussion and comments. The great part about working with WAM is that this did not have to be traditional research. And I knew already from working in mental health that looking at regional mental health was largely unexplored. Of course, there were some publications and papers, but often they had specific research questions, you know, as research tends to do. It's quite narrow, or it would be based on a town. But this really was more of an opening up, an exploration. It was pretty ill-defined if you were to analyse it from a research perspective. But it was really exciting that basically we were going to go out and have conversations about the lived experiences of people living in regional areas who were having mental health issues, what the gaps were that they saw. And also the premise of this work was that we know it's pretty solid research that people living regionally have poorer mental health outcomes. So we actually really wanted to explore that question, like what are those unique factors of living regional that affect all sorts of things, from their experience of mental health, access to services, and also what their needs are. So this slide is just a bit of fun, but I wanted to say that in terms of regional questions about mental health, WA is pretty extreme. If you can imagine the size of, the size of Australia, let's face it, we're all in this situation where we've got these massive regional areas. There's normally a capital city, and that capital city is responsible for planning and commissioning, and all those policy making processes sit within the capital city. For us, what that looks like is you've got, the Mental Health Commission in Perth, and I've worked in the Mental Health Commission, and a lot of policy documents talk about the regions. And let's face it, many people haven't visited the Kimberley, let alone understand the conditions there. I've popped in the climate data for fun as well, but just to say that the diversity across Western Australia is incredible. Like, even just looking at temperatures, there are some places that are really, really hot all year. Other places are freezing, and that's just temperature. If you can imagine the social, complexity and the context being very, very different across all of WA. So not that we have really solved that problem, but we feel like with our openness and our framework, we got to explore what that diversity means a bit. So there are 9 health regions in WA. What we did was visit 3 of them, the Wheat Belt, the Midwest, and the Southwest. And we got survey respondents from all over all of the 9 health regions. Of course, there are lots of limitations. Basically, we prioritise face-to-face contact. And so whoever kind of turned up in each community, we wanted to hear from. And there was no purposeful sampling. There weren't methods in place for who we spoke to and why. But no one who wanted to engage with us was excluded. So in a way, again, it's not pure research, and the findings are not considered generalizable, especially to certain populations, but we still think there was value in this. Also, just to be aware that we were not looking at the specific needs of any particular social group or cohort. The scope was mainly geographical. So basically we would turn up, and whoever wanted to, we would just, participate with them regardless of their identity. What this means is, there were some Aboriginal communities who wanted to participate, but our project was quite limited in how we could, properly explore Aboriginal needs systematically with proper consultation and what you would normally do if you're doing a research project with questions specifically about the needs of Aboriginal communities. So with all that in mind, an overview of the method was that we focused on 3 regions, emphasised face-to-face visits as much as possible. And we also know that often when the big agencies do regional consultation, they will go to the sort of go-to regional centres. In WA, it's Geraldton, Bunbury, but sometimes those remote towns are not visited. So we decided to focus on, wherever possible, visiting the smaller towns and hearing that perspective, because it is quite different to people living in regional towns. So yeah, we've heard from over 320 participants in 16 communities. And we also had a survey that went all across WA, 122 towns. In addition, we had 14 focused interviews, which were more like expert interviews. And for that, we did sort of proper coding, proper sampling, more a deliberate kind of methodology for those expert interviews. This will give you a snapshot of who actually engaged in our consultation. There were 410 survey respondents, and you can see that, many identified as living with a mental health condition or having experience of that, or a family member. So although that does kind of, you could argue it reflects what is in the population anyway, yeah, it's good that we did hear from people with direct experience. In terms of the framework, as I mentioned, we didn't have specific research questions, but we did have like a systematic approach to having conversations. And we utilized this framework, which we created as kind of a mashup of almost a consumer journey map and a systems kind of map of, so basically we wanted to know that we had coverage and understanding of all of the things across the spectrum of mental health, starting from the social determinants right through to recovery supports. So this informed the way we had conversations, it informed the survey design, and was also a really useful analytic framework for understanding the data. So I'd like to talk you through the findings. Firstly, we just really wanted to say how much we found that there were indicators of unmet need and mental health need, which again, it aligns with what we already know. But we think it's a really important finding that, we can't reiterate it enough, that people in regional communities are, struggling with mental health. Although we do know that, there's this myth of the resilience of regional towns, and we did find that to be true as well. The ability of people to self-organise and foster their own natural supports, manage their own mental health challenges, often without services, and, just cope with the difficulties of life. So that needs to be recognised. But on the other hand, we also found indication of high distress, and we heard anecdotally that people are also exhausted sometimes about coping and propping people up who are not struggling, and who can't get proper support for their mental health. So in our survey, we had some clinical measures. Obviously there's some cautions about what these mean, but when we use the wellbeing scale, the WHO-5, it could indicate that, about half of people weren't doing so well. And when we looked at the K10 measure for distress, we found that over a third of survey respondents had high or very high distress, which is about, I think, double what the national norms might be. And this is for the whole of the survey population. When we looked across different regions, you can see that there's also diversity, although the Midwest had a low sample size, so we need to treat that with a little bit of caution. But you can see that all of the regions aren't doing as well as the national norms, the ABS data. And, some regions are doing particularly, not as well as others. And that kind of lines up with our anecdotal data and understanding of supports as well. So what is it about living regionally that can lead to poorer mental health outcomes? Social determinants. I guess people might know this already, but it is really good to have the data around this. So a quarter of people in the survey had challenges with housing, 1 in 4 financial distress, again 1 in 4 had physical health issues, and 1 in 5 were struggling with social isolation or loneliness. So that's a bit of a wake-up call, and we heard from people a strong message that addressing mental health without also talking or meeting the needs of people and their social determinants is not going to work. There's also the myth of, the fact that small communities rally around each other and offer each other support. So yes, that is true, but it doesn't apply to everyone. There are people who are missing out on those natural supports, and some people, if they're not in that community, they feel especially isolated, and there aren't those opportunities to find their tribe or, that you might have in the metropolitan area. So in the survey, a third were not getting as much social support as they felt they needed. And when we did some analysis, we found that increased social supports were associated with lower distress. So that is something that we can't neglect. We can't just assume that because you live regionally, you're in a small town, you've got those natural supports. And that quote gives a good idea that, perhaps in different communities, the spirit of the community and their ability to connect with each other, it might change over time and it might be different in every community. Stigma and cultural barriers prevented people from getting help early. And this involved both people's idea of mental health and internalized stigma, as well as stigma of professionals and not feeling comfortable to raise mental health issues with professionals. But there were also real practical logistical barriers like transport, distance to travel. It wasn't viable to travel 100 kilometers every week to see a psychologist face to face. And, neither could pressures of living and affordability sustain that kind of support. For the people who had mental health symptoms and needed actual support for coping and managing them, we asked sort of a very non-clinical question, but we just asked, was there a time when you needed to talk to someone about stress, depression, or problems with emotions? And 76% of people said yes. However, 39% of these people reported they did not get the care they needed. So that also means they didn't get the informal support that they needed, or the services. And when, some of the saddest stories were people who were in acute distress. And, in those cases that we heard, you can really see the sort of system failing. And I think this quote kind of says it all. Basically, people wait until they're really in crisis, and it's often the police who are the ones to take them to emergency departments. And even then, the emergency departments in regional areas aren't always equipped for really complex or, crisis that they are experiencing. And so people are going unsupported. They're being propped up by community. Sometimes it works, but it's not, fail-proof. Services are literally hundreds of kilometres away. When we ask people about recovery supports and, what happens after you get out of hospital, how do you maintain your mental health and your healing and reintegration? Actually, people sometimes didn't know what we meant and they hadn't heard of this, or, so this area seems so underdeveloped that we would say that this is very much lacking in a lot of communities. But you can see from the survey data in this slide that, people actually want these kind of supports. It's not just talking to professionals or medication. People want the opportunities to have a safe place and connect with others and have a sense of belonging. And they really feel this would make a difference for their mental health and well-being. So we've started to answer the question about, life being harder in a regional context, but it's also harder to find support. I've already mentioned this, but just to draw it out more strongly, regional communities face additional barriers to getting care. The cultural barriers, the lack of mental health literacy, the logistical barriers we've mentioned, and the service barriers, because there's such limited services, it's going to be even harder to go on the wait list, deal with the costs of transport and the service, find the most suitable and appropriate support for you. So this leads to overall delayed attempts to seek help. We've also got the stigma, which again is delaying the attempts to seek help. Half of the survey respondents felt that stigma was a barrier in their community. And this was especially a worry for young people. People raised their concerns about young people not seeking help early, not being able to have these low-key conversations with others that will just sort of ease their worries and also increase their understanding about mental health and how to get help. This was an issue that came through quite strongly. People talked about just normalizing help-seeking conversations. Greater health literacy is required. The need to actually get into existing settings that are not mental health settings. They're like, get into schools, workplaces, places where the community gathers anyway, and just start to talk about mental health in those spaces. People thought that would be really helpful, because if you have those conversations at a community level, it kind of helps break down the stigma for everyone. And I mean, these are all intersecting factors, right? But possibly because of stigma, because of barriers to getting help, clinical care is not the answer until you address all those other barriers. Also, some people don't want clinical care because they feel like it's not relevant, it's not appropriate for them, or they want their other needs met through community mental health services. So, although we need to work on increasing access to clinical care, we also need to know it's not the answer for everyone. So this is a little summary that's in the report, and it's a bit detailed to, talk to in its full kind of, the full diagram. But it's just to indicate that all of these factors intersect with each other, and it's like a cascading effect of basically, you start with life being harder in communities. It's difficult to get help for anything, like whether you're unemployed or you can't find housing or you've got financial stress. It's difficult to get services to help you even in those areas. And then that leads on to distress, and then that leads to stigmatization and people not knowing how to seek help early. Then they're managing on their own until there's a crisis. And then you've got this kind of, intersecting negative feedback loops, I guess. So we wanted to talk about a remote community called Mullawa, which is, you can see, just inland from Geraldton. Geraldton is a regional centre. And so we wanted to compare, like, what is it like to live in a regional centre compared to a remote community? Geraldton has the 33 services that were all locally based, whereas all of the other 9 towns mapped had only 17 locally based services. So what's happening here is that the services in Geraldton are being funded to provide support across the region. And, that makes sense from a planning perspective. When you look at populations and how are you going to get services to the area, it's called the drive-in, drive-out model. And, on paper, there's nothing really wrong with that. But when we spoke to people, it's not really working, as optimally as it's supposed to. The limitations are, basically that people from the large regional centres drive in to the small towns. They spend a lot of their time driving, they're allocated support time driving. They don't have time for local promotional work or for people to get to know them. So they might arrive at, 11 a.m. and there might be no one there, no one, wanting their service because they don't know exactly what days or they don't know who they are. So sometimes the visiting services are not used, and therefore they're not sustained, or the service stops visiting the town. Or sometimes the service is not relevant. There's, again, not that resourced time for the service to actually understand what that particular community wants. So inevitably, this causes disappointment. It can lead to a withdrawn service. And basically that support that's there on paper is not being realised. So if you look at Mullawa, what they want when we spoke to them is they want a locally based organisation to provide access to support, because this will enable that trust that they need to engage. Ideally, there's a higher population of Aboriginal people, They would want something that they feel really safe with, that's culturally safe, culturally appropriate. Having, something come in from Geraldton was just missing the mark. And so we mapped the services at the time that were available to people living in Malawa. And we found that there was only one locally based organisation providing ongoing access, and that was the hospital. In terms of a locally based organisation delivering a program locally, which is also the ideal, there was the Community Resource Centre, and they were delivering a mental health awareness initiative. So that was good. They had that, but you can see that the rest of the supports that were technically being provided were really Geraldton based, and they weren't as integrated or embedded in the community. And from what we heard, people weren't finding it useful. So yeah, we didn't set out to talk about funding. Again, it wasn't a question that we wanted, but people actually wanted to talk to us about it. So they knew that the way things were being funded was not fair, and that they were being overlooked, especially in those remote communities. So the solutions, what do people want, and what kind of environments can we foster to enable communities to support themselves more effectively? So yeah, I mean, place-based solutions is the obvious answer. If you want to bring in the local context, the knowledge of the community, and the understanding of need, the deep understanding of need, it shouldn't be an exercise done in Perth based on population figures and money and, the way we normally do service planning. I mean, there's nothing wrong with that, but we're advocating for local leadership to be really involved, to oversee that process and feed into that process, to make sure that the funded supports are really relevant and sustained. And people think differently about what they need. They want social supports. They think that could be just as critical and just as much the missing piece as anything in some communities. So, I mean, that doesn't just mean recreational activities. It also means integrating people with mental health expertise into the activities and the groups that are already there. So making the use of those settings that already exist. 39% of people wanted to seek community mental health support. So a program delivered at a drop-in centre or a neighbourhood centre or a peer support group, just to, get that sense of community belonging, to meet multiple needs at once, and also to make it less of a stigmatizing, from their point of view, support. And this is a critical one. We think of public mental health awareness campaigns as being, sort of statewide or national, but having the really localized, tailored mental health promotion actually is the thing that will enable that community to really feel like they have sort of the permission and the safety within their community to talk about mental health and to seek help early. So we call these non-mental health supports, but it's needed, before people even get to feeling that they can't manage and they can't cope. We need to look at their whole of life kind of needs. And, in the city, it's really easy to, as I said, find your tribe or go to the yoga class or do all the things that you take for granted that, keep you well. It's much harder in smaller communities for some people to find just these supports to keep them well. We heard about activity-based supports, so just opportunities to connect and participate that are actually safe as well, where there's perhaps some mental health expertise. So it's not about being, mentally ill, as people said. It's not about even addressing that, but just about well-being and social and emotional health. And of course, we didn't have the resources to really explore this, but it's really important finding that, are these services available culturally safe? Are they being effective at keeping Aboriginal people well, connected to country, connected to family? That is, another research project in and of itself. But I guess the principle that we found applied almost everywhere was local responses, that, you can't do one size fits all, and, consultation with the communities about exactly what they need, because some communities are ready for different things and others might be just starting out and have completely different needs. So yeah, community-led responses, they have emerged as well. So we did going out, driving to all these towns allowed us to really understand what was happening on the ground, despite not being funded and not getting official support. Some communities were really self-organizing and, doing it for themselves. Sometimes this was funded through local businesses. It wasn't always sustainable. There was always the worry that the funding will be pulled, but they also knew they had to do it. So some examples might be community collectives using multi-purpose centres like a youth centre to sort of do wraparound supports for young people and have fun and do different activities, whilst also having that mental health expertise kind of feed into that, in a low-key way. There are some communities that are exploring alternatives to hospital crisis care. And yeah, in some cases, these initiatives were absolutely doing really, really well and were really sustained by local champions. And yeah, great success stories. And so just before I finish and ask you or get your questions, because you guys are a research translation network, this is like a bonus session, but I just wanted to talk about how we hope this evidence will influence policy and decision making. I guess being a research centre is, we have some kind of assets to offer in terms of providing pretty good quality evidence, and we have networks through, going to conferences, for example, or publishing. But actually critical to how we influence policy was partnering with WAM. So I really recommend partnering with a peak body, and that combination of a research centre with a peak body seemed really, really exciting. And this is probably needs to be updated because I know Colin from WAM has been, working hard. But how we saw it was that we've got the partnership with WAM, which enabled us to access influence. So, for example, they organised for us to meet with the Mental Health Commissioner together. I met with the Health Consumers Council. We presented at the WA Primary Health Alliance Leadership Committee. So we call that sort of strategic impact, to actually meet personally and talk through the key findings. And then through the UWA media, we, got the media statements released, and we actually got quite a lot of interest, which is still happening. I'm still being approached by journalists in regional towns who are quite interested in this report. So that was good to get the local media in small towns to report on this, and that's about increasing awareness. And then also we presented at the World Community Development Conference, the Rural and Remote Mental Health Conference, which is how I met Victoria and came to be here today. And so, yeah, all those additional speaking invitations, which I think is, again, great to have different dialogues with different networks. And so, yeah, this is our sort of impact model. If anyone finds it useful, it worked for us in this sense, but obviously every context is different.